in
This
front of me
conference will
today.
now be recorded.
Well,
Who do
we have you covered.
Okay, thank you.
Sure.
And my phone, I don't have, I'll probably have about an hour. We'll see. Hopefully the power will come on between now and then. But anyway, who do we have on the call?
Well, and let me see if I can identify another phone caller. Somebody just called in on the telephone. Would you care to identify yourself?
Carl Foreman.
Oh, hi, Carl.
Hi.
Okay, so we have. Hold on, I'm typing your name in, Carl.
And this is Peter. I'm on the phone in my car.
Okay, hi Peter.
Hi, Peter.
All right.
Speak up again, Peter.
Okay, this is me calling from my Toyota. You got me?
We did. I'm sure we got you.
Yeah, well, I think so.
Okay.
Anyway, we have Jake, Len, Carl Foreman, John Appler, Larry Fish, Len, I told you that, Paul Frieda, and Scott Schreffler. And one other person.
Oh!
Yeah, and he's
Hello.
actually showing us his face tonight.
Hello, Shreff. How are you? Okay.
I think you're muted. We can't hear you. Yeah, you are.
What's that?
So.
Did you say you can't hear me?
No, we can hear
Shreff?
you, but Shreff has muted himself.
Yeah.
Oh, Shreff has muted himself. Okay. It probably means he's not there. So, Len, I'm going to let you be the number one moderator, and I'll just chip in as needed because you can see on the computer what's going on. I can't see if people come in, go out, what have you.
Fair enough. Okay. Well, let's find out who wants to talk tonight. I guess we'll start with you, Jake.
I don't really have anything, Len.
Okay.
I might pipe in a little bit later, but right now I don't have anything.
All righty. Carl Foreman.
Hi. Yes. Some interesting information. Dr. Mark Stein, who I had met for a second opinion at Presbyterian, had suggested to me that, and no other doctor had recommended that I go for the color genetic test, which is a saliva test.
Okay.
And
Carl, can we come back to you? We just need to know if you need some time right now.
Okay. Yeah.
Yeah.
All right. John Appler.
I'm okay, thanks, Len. I have a little bit of muscle loss. I'm curious, how everybody else does a year in, so I could talk about that if I'm still on when you guys get around to it. I got to leave here in an hour to talk with my architect here, but I just have one small topic then.
Okay,
Sure.
John. Sure, we can get to you before you leave.
No problem.
And Mr. Larry Fish, would you like to talk tonight? Larry, you're muted.
Hi, I'm at work and trying to figure it all out. Here I am. Can you hear me?
Yep.
Okay. We can hear you.
Okay. Yeah. Nothing tonight, unless there's a lot of free time and I'm still here and you won't.
Okay.
Nothing.
Okay.
Thanks.
Next on to Paul Frieda. Would you like some time?
No, not tonight. I'm listening tonight. Thank you.
Okay, Paul. And Shreff, you must have something you'd like to tell us. You're showing us your face. We still can't hear you. Well, I guess you can't talk in that case. It's funny, I see two microphone icons for Shreff One was muted, one not. You understand what's going on there, Jake?
You see two for Shreff?
Well, I did.
I show his microphone being live.
Yeah, now I see just the one.
Yeah.
Want to try again to say something, Shreff? No, still nothing. Okay, well, if you do need time, send us a message in the chat window. We have our good buddy from the South, Southern gentleman, Sylvester Mann.
Hello, everybody.
Hi.
I don't have
Hello,
anything to say.
Would you like time to talk tonight, Sylvester?
No, thank you.
Okie doke. And I think that's everybody we've got.
Peter, what about Peter?
Yeah, don't forget Peter.
Oh, I'm sorry. He's not showing up on my list here. So.
Yeah, I think I didn't get him.
Yes, I have some things to talk about. Update.
Okay.
Yeah, I failed to figure out which phone he was on. So, but I got him now.
Okay.
Sorry about that, Peter.
If y'all don't mind, why don't we start with John Appler, since he has to leave in less than an hour. So, John, floor is yours.
Thank you, Len. I'm a year and a quarter into ADT, Lupron shots, and I just noticed at the year anniversary of my first shot, there wasn't much of an arm to put the shot into, despite the fact that I exercise, heavy weightlifting a couple times a week, 2 to 3 times, and exercise daily heavily as well. And I'm just kind of curious what the experience was from other people when you get beyond that year mark. I mean, how much, muscle loss is normal and how much is concerning?
Well, I suspect it's going to depend very much on each individual case. Are you telling us, John, that you've seen progressive muscle loss even though you're hitting the gym and exercising on a regular basis?
Yeah, I think so. It doesn't appear to be a strength loss. I can still lift the same level of weights, same number of reps, but my weight's down a little bit, and my, clearly my muscle mass is not what it used to be. And it seems to have, been a change about a year in here. And I'm now a year and 2 months in, almost 3 months in. And I'm just curious if anybody's had similar kind of path.
Well, we do have a couple of guys who've been on ADT for the long run. Maybe they'd like to share their experience.
Yeah, I did 28 months, as you know, John, and I would say that even though, like you, I was lifting regularly and actually improved and increased the amount of weight that I could lift. I certainly noticed after a year, not so much muscle loss, but I started to become a lot more fatigued, and I didn't have the strength. It was harder and harder for me to lift the same amount of weight. So, I'm like you, where you still feel that you can do the same weight, the same number of reps and all of that. I did start to find it more difficult, and certainly my endurance decreased. And I probably started to notice that after about 9 or 10 months, and it then ratcheted up. And I would say my second year on ADT was more difficult than my first year.
Okay, that's good to hear. And it does progress then, Rick? It did for you in your case as you approach that.
I'm not sure it's good. I'm not sure it's good to hear, but it gives you a frame of reference, because I don't, again, as Len said, everybody's different, and there are men who tend to sort of balance off, tail off, and they don't notice a big difference. In my case, I did notice it was a lot worse. The fatigue And really all the rest of the side effects got progressively worse as I got into that year. I don't know. Peter, I mean, how about you? You've done longer periods. How's it been for you?
Yeah, this is my third round, John. I'm on month number 8 with Zytiga and Lupron, and I don't feel the fatigue this time around, but I do feel the weakness. Yeah, I mean, I know full well that I can't build muscle mass. I can't build strength. I'm just fighting to maintain what I have, and that's my mission. But I do feel weaker. That's why I don't want to go to the beach, because I'm afraid that they'll see a 180-pound guy and kick sand in his face. I definitely feel a weakness there, and I'm gonna have to live with, because I'm around for another 3 months anyway.
Yeah, that's good to hear, Peter. I appreciate the humor. Did you happen to find a good physical therapist who, was kind of had a work with oncology kind of patients like this, or is it pretty much just do your best on your own?
No, I mean, first of all, it's not really a physical therapist that you want, because physical therapists tend to be more about crisis intervention and correcting critical issues. Like, for example, when I had a new hip, then I need to see a physical therapist. What you really need is a trainer, an exercise trainer, who is well qualified to work with cancer patients, and those people are around, and you can find them, and there are listings. So, for example, the sports medicine, the Institute of Sports Medicine offers a certification, and through them you can see if there's anybody on the island of Maui who has that certification. But really, what you need is a good trainer to work with you, if you can find one.
Good. Yes, Institute of Sports Medicine. You mentioned that before.
Yeah.
Appreciate that.
Now, one of the things you can do. There's a lot of feedback coming from someone, Jay. Can you tell who it is?
Peter Kopp.
Peter, can you mute yourself when you're not talking, please? Or do you want me to do that?
No, that's much better. Thanks, Peter. One of the things you could do is you can reach out to Regan Frederick at UCSF, especially since you're a UCSF patient, and she's one of the 2 people that does the exercise counseling there, and you can ask her if she can help you identify somebody who has the certification on the island of Maui. Is there anybody on the island of Maui who has that certification? The other thing that you can do, unfortunately I don't have a computer right now because of this power cut. I think if you go to the Institute or the Association of Sports Medicine, they may actually have a listing. I know I know that you can read about the certification there, but I think they may have a listing there too.
Okay, I'll do that. Thank you. If you get on this side of the island, Peter, stop on by, will you?
I certainly will. I'm thinking of it, because I'll only be here for another week. John, I belong to Anytime Fitness. I belong to Anytime Fitness. I think you're in Gold's Gym, right? So I've got about 5 trainers at my gym in Pukalani. I've tried a couple of them, but they don't quite understand where I'm coming from. But I'm thinking of trying another one there at my gym, and see if I can spend a day or 2 and see if I can get any insights. But I have a routine that I do.
You might want to post. I mean, Maui must have a next door. You might want to post on Nextdoor or on Craigslist and see if there's anybody with any exercise trainers with a clinical qualification, with an oncology qualification. There's about 2 or 3 different. It's not just the Institute of Sports Medicine. There are a couple of other people that offer that qualification. But you know, ask around and post and see, and there may be some trainers on the island who do have a better understanding.
Yeah, good, very good point. I'll do the research you mentioned. I'll check with my gym Powerhouse, and I'll let you guys know what I find out. Thanks a lot.
But you know, there's some. There's some other people on the call who have done long-term ADT. There's Larry Fish. There's Paul Frieda, and there's Len. I mean, Len, you go to the gym regularly. What's your feedback on getting further into the ADT and how it's affected your capacity to exercise?
Yeah. Well, John, my experience is different because I've been on ADT for a total of about, 27 months, but those were in 3 segments. So in other words, I was on ADT, took a drug holiday, back on ADT, took another drug holiday. So, it's difficult for me to speak to you as someone who's been steadily on ADT continuously. But I can tell you that certainly the longer the period that I was on ADT, the more difficult it became to maintain strength and muscle mass. So you're certainly not alone or unique in that case. The only person, frankly, that I know who will tell you that they are stronger now and have more muscle mass now than they did prior to ADT is a guy named Richard Foodie. And number one, he's an exercising maniac. And number two, he had very poor or low muscle mass before he went on ADT because he never exercised. So, that's the kind of person that might tell you that they've increased muscle mass while on ADT. Otherwise, it's a highly unlikely scenario that will happen.
Hey guys, I'd like to speak to this when
Go
you
ahead,
get
Larry.
a chance. So I'm in the later part of the 4th year of straight Lupron and ADT, and I've been keeping records for the 4 years, and I've been trying pretty hard to maintain myself, and I have noticed this steady decline in general. But I also know that when I can put in 2 exercise periods a day and really concentrate on varying weight training with some kind of cardio aerobic days, and then add something like meditation and or yoga a second time during like one day weight training, next day cardio, and then a second period during that day of doing walking or doing stretching yoga or doing meditation or Feldenkrais. I'm a Feldenkrais practitioner and I love that work. It's kind of obscure, but it still is. I firmly believe I have proven that I can gain muscle mass if I really work at it. I did it very interestingly, worked at it because they were having trouble sticking me for blood tests, and I really concentrated on like curls, triceps, biceps, hand strength and grip strength, and did increase my strength and my muscle size from my fingers to the top of my arms. And now I'm working on chest and back, and I find that I have been improving, but it requires really concentrated attention with following your own body. You have to do what you can, and you can go with the flow, and you need more time to recover. So if you work like a weightlifting pattern for lifting weights, and you're doing, chest one day, back another day, shoulders another day, core another day, and legs another day, and trying to work 6 days a week, you might find that period takes 2 weeks, not 1 week. You might have to rest 1 or 2 days after a workout before even doing an alternative exercise. You can't just do body parts twice a week or 3 times a week. But if you do that, you can stop and you can reverse. And my major goal in life is to cut my working hours and be able to really put in those 2 full cycles with a lot of rest as much as possible. And I believe it's possible to do pretty well. But I've been slipping for 4 years straight.
Yeah.
That's
really good to hear.
And I'm still at it. It's still my goal, and I'm still working at it. And I keep these intermittent records, so I know when I could do 80 sets of lighter weights. Now I can only do 40 sets. But in general, if I can do that 2 exercise periods a day and alternate weights with aerobics day by, 1 day weights, 1 day aerobics, and something else during that day, then I find that I can maintain and sometimes build or slip very, very minutely, so much that I can't notice. But it's when I get a crisis at work or I'm busy for a few weeks, I lose a lot and it's very hard to regain. So really, you have to really make it one of the major things in your life. That's my opinion, and I don't know, I've been still working at trying to cure myself before I speak too strong.
Yeah. Very encouraging. Was that Larry talking?
Yeah, that's Larry Fish.
Larry, very
Larry,
encouraging.
I really agree with you on that. I mean, I found, first of all, I put on not a lot, but I put on enough weight. I mean, I peaked out at about 169 when I was on hormone therapy, and I was exercising every day, and my normal weight before that was probably somewhere between about 152 and 156 was what I was normally at. So I definitely put on a whole bunch of weight. I also found that I could lift a lot more because I was lifting regularly, because I really disciplined myself to use weights 3 times a week. And on the other days, I was doing aerobic, or sometimes I was doing some aerobic on the same day as the weights as well. But I definitely could lift more then, ironically, than I can now. But the other thing you have to take into account is that as you age, you lose around 5 to 10% of your strength and your endurance each year. Once you get over 60, you decline. And it's hard to stop that. I mean, I'm just finding now, I was thinking about it last night. I took about 6 or 7 months off from rowing because I didn't have a boat, and then I had my hip replaced, and this and that and the other. And only now am I finding that I'm starting to get my strength back. I'm still way slower than I was about 18 months ago, but once you lose it, it's very hard to build back. I absolutely agree with you.
Yeah, good. Yeah.
And Rick, I agree with. And Rick, can you hear me?
Sir.
I also was thinking to mention there is also that question of, as I went from 66 or 67 to now I'm 70, going to be 71. There's also that factor, so it's hard to balance that. I know it's going to be a slow decline, but if you can get in 3 weightlifting and 3 aerobic periods a day, and hopefully some other stress reduction, I think you can really maintain pretty closely and just have a very slow, natural slide.
Yeah, that's great.
Oh,
very encouraging. And thanks, Larry. Thanks, Rick.
Oh, my electricity just came back. I'll be with you guys in a minute.
Okay, Rick.
All right, I'm not hanging up until I see you.
All right.
Okay.
Anyone else want to comment on John's?
Yeah, I've had this is Paul Frieda. I've had terrible time with weakness, but I attributed it mostly to the fact that I have serious back problems. And about 9-10 months ago, I was so bad I could hardly get out of bed, and I had to walk with a walker for about 2 days. And so the inactivity, I think, atrophied me for a while. But I can see now that also being on ADT for 3 years has probably also contributed. So I have just recently joined a gym, and boy, it is one rough road back. I can barely do 20 minutes, and I don't lift anything heavy. I just do, some of the leg curls and maybe a little rowing, very gentle rowing and stretching. But I can see it's going to take me 4 or 6 months just to get back to anything that's reasonable. And on top of that, I put on a tremendous amount of weight, and I don't even want to tell you what the number is. So I've had a lot of physical problems with this sort of thing. So you're not alone, struggling.
That's good feedback, Paul. I appreciate that.
Sorry, go ahead. Please go ahead, John.
No, I appreciate that, Paul. The key point you mentioned there was, don't lose it. Try and keep it on. And I'm just curious if Larry, you were adding like heavy protein to your diet in addition to exercise, or just standard protein.
Well, I've also just started, religiously taking the calcium, and so I was remiss on that for a long time.
Yeah.
And I keep. It's funny you should mention this, because I've gone through this. I have pea protein and whey protein, and now recently I just bought like a big thing of creatinine, but I'm not taking them. I can't bring myself to start to take them yet. When I think about taking
So Larry, what do? You buy them and you put them on the shelf, and you look at them in the morning.
And after a year or two, I decide I better throw them out, and I just did it again. But I did make cranberry. I made fresh cranberries yesterday, and I blended them in with other juices, because I always get worried about like kidney stones or some effect from the taking a lot of protein.
Yeah.
So I've just really made cranberry juice, and I'm ready to take the creatinine. I'm ready to follow that, and I have the strips for testing your ketone bodies, and I've never used one though. But anyway, I do think it's good to think in that direction.
Larry, are you checking with your doctor before you start taking these supplements?
Yeah, of course not. Not really.
Probably wouldn't be a bad idea.
I give it. Yeah. I have my long list for my doctor, and I really can't get into the insanity that goes on in my mind about all these details. So right now I'm just looking at it, so I'm not so worried.
Okay.
I think that Jake makes a really good point. I think there are some supplements that it really is smart. I mean, I'm not sure that if you're crushing fresh cranberries and you're doing something with them and eating them, that you need to worry much about that. But certainly, if you're going to add something like creatinine, I do think that it does make sense. And any vitamin that you supplement significantly, like vitamin E, for example, you definitely want to be checking in with your doctor.
Len,
I would say.
Yeah, Len, correct me if I'm wrong. Creatinine is one of the things that they test on blood. Isn't that one of the ones that if it's low, it's good, I believe?
Yes, but Larry is actually mispronouncing. The protein he's talking about is creatine. It's different from creatinine. The health supplement is called creatine. It's supposed to help you build muscle mass. Creatinine is a measure of kidney function. That's what they test for in your blood. Two different things.
Okay.
Yeah. And John, I would just say, if you feel like you are eating sufficient protein in your diet, there's no need for any protein supplements.
Okay.
If you're having chicken and fish and turkey at least once a day, if not more, you probably don't have any protein deficiency, and there's no need for any supplement.
Good.
Yeah, it's
I'm strict about
always better to get your nutrition through whole foods rather than any kind of supplement.
Yep, good advice. Thank you, Len.
Sure.
Yeah, and I'd like to come back to Paul because I really
just want to say that creatinine, it's the byproduct of creatinine and creatine phosphate. The creatinine, I forget which is which, creatinine phosphate. And it is something you have to worry about because it can affect the levels of creatinine in the blood. That's the thing you have to monitor. It should all be cleared with no problem if your kidney is functioning well. But if it's not, you'll get a buildup, which is really the problem.
Len, did you want to respond to that?
No, I just wanted to make the point that Jake had asked, is creatinine what's measured in the blood? The answer is yes, but but the supplement is called creatine.
Okay. So
I misunderstood Larry then. I misunderstood him. My apologies.
So I just want to come back to Paul Frieda because I want to give you a big virtual back slap, Mr. Frieda.
You mean I'm a bad boy? I'm a bad boy or a good boy?
Good boy. I want to give you a back slap.
Okay.
I want to say that. I want to say attaboy.
Yeah.
Because, I mean, I know that how difficult it's been for you and that you wanted to exercise, but between pressures at home and putting on weight and your back and this and that and the other, it's been really, really hard to get it together. And I don't think not just me, but I think all of us on this call who are regulars are really proud of the fact that you're at the gym and you're working out. And I think that's fantastic. And I'm really, really pleased to hear that. And I want to tell you that that 4 to 6 months, if you can turn it around in 4 to 6 months, that would be amazing. I mean, you're probably looking at a year to 18 months of building very slowly. I mean, the key here is you got to build slowly. And I don't know if you're getting any help at the gym, if you're talking to any of the trainers, if any of the trainers are in fact certified, like we talked about before. But the one thing I can tell you is go very slowly. I mean, go longer than you think you need. If you're curling with 10-pound weights in each hand, hold them for a week longer than you think you need to.
Well, that's one of the things is the reason the gym is that I can't stand and curl. My back won't stand it. So the machines give you nice support, when you sit in the chair and so that's one of the reasons why the machines are very, very helpful for me.
Right, but if you've got the machine on 10 pounds when you're curling or 15 pounds, stick on that 15 pounds before you move the weight down to 20, longer than you think you need.
Yeah, go more slowly. Well, yeah, for sure.
Go very slowly, and you'll suddenly, I think what a lot of people find, and you may find, is you'll spend 3 months, 6 months, and you won't see anything, and then all of a sudden it'll happen, and you'll suddenly feel you're getting stronger, you're starting to lose weight. It takes a long time, and then when it does happen, it happens quicker. I mean, ask Peter. Peter, I remember when we first started working with Peter, and he was doing a little bit of exercise, but not a lot. And wasn't regularly in the gym, and then he started going to the gym regularly, and boom, all of a sudden, it made a huge change, right, Peter?
Yes. Consistency pays off.
Right. For sure.
So I'd be a little concerned about I think we're getting feedback from Peter again.
Yeah.
I'd be concerned about taking care of the back issue first before you start exercising seriously. Are you doing anything to make sure your back is strengthened and protected, and chiropractor or physical therapist?
No, I try not to do anything that might be risky to the back. Like for example, they have a nice raised table where I go on there and lie on my back and do my leg curls and my twists to stretch my back. Because when I've gone to the physical therapist about my back, that's what he showed me to do. And so I'll do that before I actually go to the machines. Also, not only that, before I'll ever touch the machines, they have a gym there, and I go and shoot baskets a little bit. But I'm embarrassed to say this, but I go to the foul line, I can't get the ball to the rim. I mean, that's how weak I am. I mean, it's profoundly embarrassing, but I'm just, but anyway, I'll just go under the basket and shoot little layups for 10 or 15 minutes and just get my body moving, and then I'll go do stretches, and then I'll go to the machines. So I'm trying to be careful. And the other thing actually I'm doing, which is that I'm a little worried about my heart. I have a tendency to be over ambitious, and I might do the third set when I really should be only doing 2 sets. And so I'm actually having my heart checked out, and I've had an echocardiogram, and the doctor said I look good, and I had a nuclear stress test, and I'm going to get the results of that next week. So I want to make sure that I can't hurt myself because overexerting myself. So I'm trying to do everything right, but the biggest problem is all this weight. I mean, I really need to lose this weight somehow, and so I got like a triple whammy here, and I'm just trying to do the best I can.
Paul, this is Jake. Do you take metformin by any chance for your cancer?
Take what?
Metformin?
Metformin? No, I only took Lupron, and I'm going on my Lupron holiday. Starting my next shot would be in November, and I'm not going to have that shot. So we're going off the Lupron in November. But what would Metformin do for me?
Well, we've talked about that on this call before. There are some studies that suggest that it's beneficial for prostate cancer. It's usually a medicine for diabetics, and you might have a hard time getting someone to prescribe it for you. If you can get it prescribed, it probably will help you lose some weight.
Is that right?
Yes, sir.
Okay, I'm going to see my primary care physician in about 2 weeks. I'll ask him about that.
Yeah, what kind of blood glucose do you have? Do you know?
Well, it was high enough that he did a A1C test.
Right.
Yeah, he had me do the A1C test, but he said I'm okay. But I'm I may be close to the line somewhere there.
Pre-diabetic. Yeah, if you might be able to convince your general practitioner to prescribe that for you, because there is some studies that suggest that it is helpful for cancer, and it definitely does help with weight.
Okay, thank you very much. I will definitely talk to him about that.
Yeah, just make sure you take it with food.
You have to take it with food.
Yeah, otherwise you'll have some stomach distress.
Okay.
And we've talked about metformin, as Jake says, we've talked about metformin pretty regularly on this call, and there's more and more evidence that it has value. And if you look into the archives, you should be able to find conversations about metformin. Probably we haven't talked about it in maybe 9 months or so, but also we have references to those studies, and we can provide them to you, but there's probably very little downside in taking a moderate amount of metformin, and there's a fair amount of upside.
Right.
Okay. All right. I'd never considered that. Okay.
Same thing with the same thing with statins. Are you taking a statin, Paul?
No, haven't even considered a statin. Should I be taking a statin? I mean,
Yes. I mean, there's lots of evidence, especially with respect to prostate cancer, because the lower your cholesterol, the less likely you are to make testosterone within your own body.
well, my cholesterol is pretty low. I'm pretty good about staying away from a lot of fat. I think I'm down like about 160 or something. Isn't that pretty good?
It is, but it's again, statins and metformin are really thought to help, and they have very little downside. It's something that you should certainly be talking to your guy about, your Met Schwarzberg, and or your PCP. But it's just.
I'll talk to both of them about it.
I mean, there's again, and you can do some research on the net and go to Prostate Cancer International and do some research there. Len, do you have thoughts on that?
I'm sorry. What thoughts in particular? I was daydreaming.
He's zoned out on us, huh?
We're talking about
asking if he was sleeping, Rick.
Statins?
I'm sleeping.
Statins and metformin.
Oh, well, very controversial. A lot of doctors like Snuffy will swear by both. Others, like my own oncologist when I was at MSK, said you're introducing more side effects when you introduce more drugs. So it's a controversial topic.
So let me just comment on that. It is controversial. I'm not a big Snuffy fan, as you all know. But I think that over time he's been shown to be correct, and the side effects from both statins and metformin in moderate doses are really pretty low.
Correct.
So again,
it depends on the person. Some people say they have serious GI issues, diarrhea.
Yeah.
From metformin. Others say that the statins give them joint pain and weakness.
Yeah.
Others, it doesn't bother at all. So I guess, you try it if you're one of the lucky ones who doesn't have the side effects.
Well, the metformin, that's the reason you take it with food. It's very important to take it with food because you will have some gastrointestinal distress with it otherwise.
Well, I mean, the other thing with the metformin is you start with a lower dose and you build up. Start with a 500 instead of 1,000. Anyone else on this call right now would like to address statins or metformin?
One other thing for me is on the metformin. I asked my doctor for the extended release version, which releases it slower into your system rather than a big shot at one time. And that seems to help with the, work. I mean, it keeps my glucose down, and it also, keeps my diarrhea to a minimum, even though I do still have it occasionally.
Mm-hmm. Mm-hmm. And how much are you taking? How much are you taking, Jerry?
I take 1,000 milligrams.
I mean, I think a lot of people who have the issue with 1,000, 500, they're just fine.
Yeah, some people on this call have actually taken 2,000.
Really?
Yeah, I don't remember who it was.
Uh-huh. Uh-huh.
Rick, Joel here. I've been taking statins for about 15 years now with no side effects. I've been taking metformin for the past 2 years. I take 500 in the morning, 500 at night, and with no I I've had 2 hip replacement surgeries in the past 3 years, so I haven't lost a lot of weight. But from a prostate cancer standpoint, I don't know if it's been helping or not, but at least I'm taking it because Snuffy Myers told me to take it, so I'm taking it.
Yeah.
And just one other thing, Rick, I'd like to add is, if I recall correctly, the studies that showed benefit to metformin were in patients, prostate cancer patients who had diabetes. I'm not sure it's been tested in clinical trials, at least in patients who do not have diabetes.
I think you're right. I think technically, where they saw that metformin had a preventative effect in patients with diabetes, but there have been many trials there have been several trials, and I can send them to you, Len, afterwards, where they've tested metformin
in non-diabetic.
Yes.
Yeah, I would like to see that.
Yeah, I mean,
The problem is getting your doctor to prescribe it for you if you're not diabetic or pre-diabetic. That's going to be the hard part.
Yeah, it is.
Yeah.
It is.
Hey, Rick.
Yes.
This is David in Washington. I seem to recall reading a couple articles about folks that are on long-term hormone suppression, that it ups their risk factor for insulin distolerance. And maybe that's why there's thinking about the use of metformin in that setting. I don't know if you recalled seeing any of those reads or not, but my foggy brain is recalling that.
Yeah, I mean, there's certainly a big risk with metabolic syndrome when you're on long-term ADT. But what I've seen doesn't really relate to the metabolic syndrome as so much as it does to constraining the cancer. I mean, the theory, on a very, very simple level, as I understand it, is that the less sugar you have in your body, the less glucose you have, the less food there is for the cancer to generate, because cancer loves sugar.
Right.
Glucose, and I think that's probably the reason. I'm not sure, but I think that's the reason.
I think you're right.
I think that's true in general for cancers, but that prostate cancer, it is less true that sugar is an issue.
Yes, it is absolutely less true because prostate cancer feeds on testosterone and androgens more so.
Actually, yeah, I believe for prostate cancer, the big unique difference that I've read about it is that it has this unique ability to utilize citrate from the Krebs cycle, and which isn't really normal. It has something to do with prostate cells being designed to secrete and change the seminal fluid pH, for proper insemination or whatever. So it actually uses citrate in the reverse fashion that normal cells do, and that, from my reading, that's why it's not as vulnerable to glucose manipulation.
Yeah, that's above my pay grade. I have to defer to you and Len on that one.
Well, it's just something weird. I mean,
what I recall also. I don't, and like David, I don't recall the details, but I know that prostate cancer has a way of sidestepping any attempt to deprive the cell of glucose. It turns to other metabolic pathways to keep feeding itself. Yeah.
It's also, from what I've read, it's also connected to a really strange disruption of normal zinc metabolism that is connected to citrate, and that it preferentially gets rid of zinc as part of the citrate metabolism, so that prostate cancer cells are actually low in zinc, whereas healthy prostate cells love zinc.
Yeah, that I do know about. I do know a little bit about zinc and prostate cells, and the zinc is attracted to prostate cells. Yeah.
So I take a multivitamin that has zinc in it. Should I not be taking that?
Well, I don't know if zinc is good or bad. I just know that it's attracted, and that's the basis of the study that they're doing with I forget what it's called, with antabuse. What's the name of that drug? And what's the name of antabuse, Len?
Yeah, you've got me. I don't recall the name myself.
Antabuse.
Yeah, antabuse is
disulfiram. Disulfiram. I just looked it up. So,
yeah, sulfiram. Right.
So disulfiram is attracted to zinc, as is our prostate cancer cells, and that is the study that they're doing, that Dan George is doing at Duke University.
Yeah.
Remember?
Yes, yes. Don was trying to raise
God
money.
rest his soul, was promoting, and and Dan George couldn't get it funded because it basically just uses zinc and disulfiram, and disulfiram will kill off prostate cells. And
you know, it had something to do with copper also, Rick. Only unfortunately, I don't remember the details. You remember?
Maybe it was copper. Maybe it was copper, and maybe I'm totally off the wall. Yeah.
No.
Yes, it was copper. It was copper.
Yeah.
Okay, thank you, Peter. That was. So I just took you guys down a cul-de-sac. Sorry about that.
We're not listening to you ever again.
That's probably a very smart thing to do. Okay, well let's forget that. Where were we? Sugar. We were talking about sugar. Somebody sent me a whole article on how honey has anti-carcinogenic qualities. And I wrote back and said, well, I find this strange because honey has glucose, and glucose is certainly not anti-carcinogenic. So I have yet to read the study. I got it last week, and I want to send it on to Greta McCare and see what she says about it. So we have another caller. Would you like to identify who that might be?
Yeah.
Okay.
Someone on the telephone.
Sorry? Number 9. Caller number 9. That's fine. It's just somebody wants to listen in.
It's Shref. I was on mute.
Oh,
yeah, I can't get my computer to work.
Hello, Shref. Well, I didn't mean to mute you. I meant to fill in your name. Well, that's okay.
I got it.
Yeah, that's great. Okay. Where were we now? I mean,
we can move on to Carl Foreman.
Yes, we should. But before we move on to Carl Foreman, can I just give you guys 2 quick updates on 2 of our guys who I have heard from in the last 2 or 3 days? Actually, 3 updates.
Please.
First of all, Jay Mills had his HDR brachytherapy treatment yesterday with Joe Shu in San Francisco, and I spoke to him this morning, and he's doing very well. He's very happy, and he's going to be seeing Mac Roach for his treatment, for his IMR treatment. So that's certainly a positive. I heard from Ken Anderson, who's off to Australia, I think this afternoon, and his PSA went up again from 0.6 to 0.79. So there's clearly a pattern. It's gone from 0.5 to 0.79 over 2 or 3 months. So when he gets back from Australia, he's promised me he's not going to be too anxious, but he's going to be talking to Paul, his MDA doc. I've just lost Paul Korn. He's going to be talking to Paul Korn, and my guess is that he'll start some type of second-line anti-androgen because he hasn't done that yet. There is a really interesting lutetium trial, but you have to have failed, or I shouldn't say failed, but you have to have been on and taken at least one second-line anti-androgen that he hasn't done. So hopefully he'll get onto a treatment that works for him for some time. And then I've been going back and forth with Professor Bill, and Professor Bill has a penchant for endurance gardening. And about a month ago, he spent the whole weekend in the garden, and then he basically had a relapse and finished up in the hospital. And he promised me that he would be more respectful of himself with the gardening. And then I heard from him this week that he was in the hospital with a compression fracture of a thoracic vertebrae. And I said, don't tell me you've been doing more endurance gardening. And he said, how did you guess? He said he picked up a bag of compost that was waterlogged, and it was much heavier than he expected it to be. And so he finished up damaging his back. He is actually in Boston today because they're going to biopsy one of the lymph nodes, but they put that off for a week. So he's going to be staying with his brother in Vermont and coming back down next week to get that done. So those were the 3 updates I wanted to give you with mixed results. Okay.
Rick, what is the treatment for compression fracture?
I don't know that there is. Well, I shouldn't say that. I mean, the surgery, which is what Eric had. They go in and they basically build a frame around your spine.
So you don't know what they did with Bill?
I think it was just pain, and he just sort of unrest.
Okay.
I don't know what else they did, but there's not much more that I think, I'm not sure, but I think that there is cement. They can pump cement into the vertebrae, but I don't know if that's what they did for him, but they can pump cement in, but I don't know how successful that is. Do you know anything about that, Len?
Well, I was going to say the same thing. I think they just might try some type of spinal fusion surgery if it isn't too dangerous to do it. But I don't really know. I think a couple of you guys have frozen. Can anybody hear me?
Yeah, we hear you.
I can hear you.
Yeah, I can hear you.
And you're
okay. Rick is frozen.
Yeah,
it might only be Rick.
Yeah, it's just Rick, I guess. Okay.
And Carl.
Well, that's
Carl,
all I have to say about.
No, he's not.
I'm not frozen.
No, he's not. I'm sorry.
Carl's good. Yeah, I don't know much about spinal fractures and what they can do for it.
Maybe Rick will lost power again.
Yeah, possible.
Possibly. Should we send him a message?
No, he just booted himself off.
Oh, yeah. Okay.
He'll probably be calling it on the phone or back.
All right. Well, shall we move on to Carl then?
Okay. Oh, there he is.
Oh, okay. Rick, we're going to move on to Carl, if okay with you.
Absolutely, yes. Sorry, my internet connection just went. We're still going through big storms here, so if you lose me, I'll come back in on the phone.
Okay, I guess to add to the conversation concerning exercise, the gym that I belong to here in New Jersey is part of a chain that are affiliated with various hospitals throughout the state. The gym in Princeton is affiliated with Penn Medicine Hospital, and I belong to that gym, and they have a cancer wellness program, which I had subscribed to most recently. And it's a program that consists of one-on-one sessions with a personal trainer. It was an 8-week session, 16 personal training sessions for a total of $800. And I did that for 8 weeks. The training classes were set up by various doctors throughout the hospitals in the state, and they specifically focus on cancer patients. So as part of my membership, I have a nurse assessment every 3 months with a nurse on staff. And I had my most recent nurse assessment. And it also did show that my muscle mass had declined, although I continued to do regular exercise. Although I can't say it was extremely vigorous or very heavy. They were being very careful with that as far as putting too much weight on. And also one of the questions I had for the rest of the group is that with everyone doing the exercise, like for me having metastatic bone prostate cancer, I would be concerned with the possibility of having any potential fractures. So to the extent that I would expect I have to be somewhat careful with the amount of weight that I should be lifting.
Well, I would say the following with this. I mean, certainly if you're on long-term ADT with metastatic tumors, exercise is definitely still recommended. But the issue is that you do it hopefully under some level of supervision with an exercise trainer who has this ACSM, American College of Sports Medicine, ACSM certification or something comparable, because they're going to work with you to make sure you don't overstress yourself.
Yes.
But it's good to stress those bones in the right way because it helps to build the bone. And it helps to avoid bone loss. Right. So while Jake is there nodding, that could be a problem. There's a good reason not to exercise. I know what's going through Jake's mind. He's thinking to himself, oh, now I know why I never go to the gym. That is.
I have it written across my forehead.
Yeah, it comes on in like neon lights, Jake. It goes like right across your forehead. It's actually not a good reason not to exercise. It's a good reason to exercise. And my guess is that the trainers that you're working with, Carl, probably have this ACSM certification.
Yes.
It's probably the best one, the ACSM. Regan Frederick, who I mentioned before, was she and her colleague were the very first people to get it about 5 years ago, 6, maybe longer now. Maybe it must have been about 2010, 2011. They were the very first people to get it in the very first bunch. And those people do know what they're doing. So I don't want to discourage you, but what I do want to do, I want to say the same thing that I said to Paul, is that go slowly, build slowly. As long as you go slowly and build slowly, you should be fine. Now, I will say this, because I said it to Professor Bill. We know that prostate cancer loves the spine. It's one of the early places that you see it metastasize. And so you've got to be respectful. And if you have significant spinal metastasis, I think in that instance, you've just got to be careful how much stress you put on your spine. So again, if you know you have certain areas where you've got heavy metastasis, then you've got to be talking to an exercise trainer that's well qualified about what sort of exercise you can do. But overall, I wouldn't don't let it inhibit what you're doing. That's
right.
That's what I would. But that's not medical advice. That's from what I know as a trainer, training and working with weights and what have you. I want to encourage you I want to encourage you to exercise, but to speak to people that are knowledgeable and what the right exercise is.
Right, and it is monitored and it is supervised and doctor supervision, whatever. So
okay,
that's that part. So those of us who are on Xgeva, I started on Xgeva 2 months ago. I had my second shot about a week ago, and I'm experiencing some. I don't know. I don't want to call it pain, but maybe it's psychosomatic. But I'm feeling something in my jaw. And whether it's serious enough or not, I've expressed it to the doctor. I actually called up, I think it's Amgen, who produces Xgeva, and spoke to their patient hotline. And they said, well, typically you don't really, it's significant jaw pain, and it usually doesn't occur until you're on the drug for a year. And it's and somewhere in the neighborhood of 1 to 3% to people who have that side effect. So I'm thinking, okay, well, I don't want to be overly cautious, but I don't want to go too far along. Again, I've only had 2 months worth of it. I'm wondering whether it's something that I really definitely should be following up on, or just, keep active surveillance, as they call it.
Who would like to address that? Jake, you've been on Zometa for years.
Yes, I've been on it for 6 years. It's not the same thing as Xgeva. And you're right, Carl. The prevalence of it is between 5% or so, approximately. And what I've read is that the longer you're on it, the more likely you are to have problems. It's a cumulative type thing. I seriously doubt if you're having problems after just 2 months. I don't know that. I'm not a doctor either, but I seriously doubt 2 months would be doing it to you. And if you think it's a problem, ask your doctor to give you a bisphosphonate instead of the Xgeva. That's an infusion, unfortunately, rather than a shot. It's an infusion. Takes about half an hour at the oncologist's office once a month.
Okay, I do have an appointment with my urologist in 2 days to get my second shot of Eligard. It's been just about 3 months, so I'll be seeing him the day after tomorrow. I'll bring it up to him as well and get his opinion. So that's on it.
Len, do you want to say anything about Xgeva?
I agree with Carl's doctor, everything I've heard, and with what Jake said as well, that it's to the extent that you may develop ONJ, osteonecrosis of the jaw, is something that would certainly not happen after just a couple of months. As Jake said, the longer you're on it, the greater the likelihood. Could be a little bit psychosomatic there, Carl. But as Jake said, also, if you're more comfortable switching to Zometa or bisphosphonate, you could do that. But I would just follow your own instinct with the active surveillance and
Right.
just, yeah, it'll probably go away.
Okay.
Now,
Hopefully your doctor, or hopefully you had your teeth checked before you started on it.
Yes, absolutely. Yeah.
Okay, good. My oncologist didn't tell me anything about checking with my dentist before I started it. But yeah, that that's where we end up having a problem a lot of times, is when you get a dental procedure.
right,
Yes.
right. And did your dentist do X-rays?
Yes, digital X-rays. Yes.
Okay, so if there was nothing on the digital X-rays when you started, I think again I'd agree with the other guys. I mean, I don't know that there's a reason to go from Xgeva to Zometa. I mean, they do have different methods of action. I'd also be more inclined to talk to my medical oncologist and my urologist about this. Who's giving you the Xgeva shot?
It is part of the Cancer Institute of New Jersey, so I guess it's under direct supervision of the oncologist, but is a separate area that I go to where they do the infusions and the injections.
Right. So I would be talking to your oncologist. I know it's not Kim. Kim's the surgeon, but
Right, Soraya.
Who is it?
Soraya.
Soraya. So, I'd be talking to Soraya about that and asking him if he thinks one is better than the other. But I would just tend to agree. Is anybody else on the call on Xgeva, or has it had experience with Xgeva or Zometa? Okay. I mean, I did Zometa. I had 3 Zometa infusions, but they were a year apart, and they were because I was on long-term ADT and because I was osteoporotic. I didn't have any side effects from them at all. But that's just that's my own anecdotal experience.
Okay.
Tell us what Stein had to say about getting the old germline test, because we've talked about that a few times here.
Oh, okay. And I've had multiple second opinions. He was the only one who actually mentioned the use of the color test. I had it done and got the results back a few days ago.
Oh, good.
And unfortunately, it shows I'm positive for the BRCA2 gene.
Oh, uh-huh.
So I had as part of the program with Color, I had a conference call with the genetic counselor for a half hour, and we had a discussion, and she strongly recommended, I have 2 daughters, so she strongly recommended that I discuss the results with them and that they themselves get tested. One of my daughters I spoke to, and she happens to be a nurse, so she said she would follow up. There's a way on the Color website that I put in her email address, and she'll get an invite, and it'll be a reduced price. Instead of $99, it's $50.
Yeah, I mentioned that to you.
Yeah, they're also having some kind of a special because it's Breast Cancer Awareness Month that they offer their tests at a reduced rate just to the general public. My other daughter, my older daughter, I have not yet given her the news. Her dog passed away just 2 days ago. So we had a dog for the past 13 years. She is a wreck.
Yeah,
so I wasn't about to put that on to her. Although my wife is saying we have to talk to her sooner than later. The genetic counselor said because of my bloodline, I am Jewish, and the Ashkenazi Jewish bloodline is one of the criteria. And so it's kind of interesting because my immediate family, there had been various types of cancer, in the family, all of whom had passed away. My father passed away. I was 2 years old. He had something called lymphosarcoma. When I mention that to doctors, they're not even familiar with that term anymore because I don't even know if it's used anymore. But he was in his 30s when he passed away. My mother passed away just shy of her 66th birthday. She had renal cell carcinoma. And my only sibling, my sister, passed away at age 43 of astrocytoma, which is a brain cancer. And I was, for years, I kept asking all of the doctors, I said, should I be concerned? And everyone has said to me is that there's no hereditary relationship with any of these cancers. So, you know, in hindsight, of course, if I had this test 10 years ago, 15 years ago, before I had prostate cancer, because they said men who have the BRCA2 gene are susceptible for metastatic prostate cancer and advanced. And here I am, and that's what I have. So,
well, I mean, the question is, if you would have known 15 years ago, what would you have done? Prophylactically, would you have had your prostate removed? I mean, it's possible. I mean, the word is that, what's his name from Google? Serge, what's his last name? The principal of Google.
Brini, I think, maybe, B-R-I-N-I.
Yeah, that he had a prophylactic prostatectomy because he's BRCA positive. But I want to say a number of things to you. First of all, I will connect you when the call is done. I'll connect you to Professor Bill. And because Bill learned that he was germline BRCA positive, it raises a lot of issues. Some good, some bad. The good are that there are certain drugs that are out there that could be very helpful to you in managing your disease long term. The bad personally is that I think that making a decision to do surgery is probably a lot wiser, because we seem to think that there is a susceptibility for men who are BRCA2 to radiation. The cells are thought to be more sensitive, so you can do more damage with the same amount of radiation. And that's a problem that Bill had, significant problem. And Bill's urinary tract was burned up pretty badly from the radiation. He didn't know he was BRCA positive. So it limits you somewhat in what you can do. Now, a lot of doctors won't even know about this and certainly would be skeptical, but there are more and more who are recognizing that there are radiation issues around the BRCA gene. The other reason I really would like you to speak to Bill is because there have been issues. And I'm trying to put this in the most diplomatic, political fashion. His knowing that they are BRCA positive has impacted one of his daughters very significantly. The other one, not so much. The other one is, his other daughter is truly amazing. She got written up in Forbes this week for her nonprofit work, and she's opened an office in the Vatican. I mean, she's just amazing. We've talked to her about her and she's the younger one, and she's pretty fine with all of it, and she's handling it well. The older one is not handling it so well. And one of the things that's come out of this is that we've talked about creating a mutual call for the offspring of people who are BRCA positive, because it puts a lot of pressure on your offspring as to what to do. Do they need a prophylactic mastectomy? Do they need a prophylactic
removal of the
oophorectomy? Exactly. And Bill has, unfortunately, Bill has the T-shirt. So I'd love for you to talk to Bill, and I know he'd be happy. And I also know he's in Vermont all week, so he's going to have the time to talk to you. So I will make the connection. The third thing is that we are Jim McCoy, who is on this call from time, is also BRCA positive, facing metastatic prostate cancer at an early stage. He had treatment years ago. His disease came back. He's somewhat metastatic. He's very committed to working with the BRCA gene and prostate cancer. I know personally Alan Ashworth, who is the president of the Cancer Center at UCSF and who discovered the BRCA gene and who has created a clinic at UCSF for, it's called the Center for BRCA Research, I think. The other place where there is a clinic, and you should be in touch with them as soon as you can, is at Penn. Because you already have some relationship with Penn and you're closer to them. But
Penn Medicine.
At the University of Pennsylvania.
Oh.
I guess it's part of Fox Chase. I think it's affiliated with Fox Chase. But I can look it up for you and tell you. But there are only two BRCA clinics in the country, specific BRCA clinics that are focused on BRCA research. And one of them is at UCSF and the others at Penn. And I think that I would be wanting to meet with somebody there and asking them what their opinion is on the best way to manage your prostate cancer. I mean, probably I don't see, again, I'm not a doc, so this is all just logic, but I don't see any reason why you wouldn't proceed with the with debulking through surgery. I don't see what the downside could be, but I would definitely want to get a BRCA expert onto my medical team knowing. I mean, just this week, I was reading Rubraca. Rubraca is a PARP inhibitor. Do you know about PARP inhibitors?
Well, I was reading recently about that, and there's the Triton 2 study that is specifically relating to that, and there's a particular drug that's been studied, and I discussed that with Dr. Soraya, and he said that drug is more with those who are castrate-resistant metastatic, and I'm not at that point yet.
Well,
because he said that the cancer is...
The answer is we don't know. The answer is the test that was done, and I can send you the information, and this is the Rubraca study that came up this week, because they published a poster at ESMO in Europe, in Madrid this week. Before that drug, there was a drug called olaparib. And I'm just trying to remember the name of the olaparib trial. But one of the national experts on this is Professor Bill.
Wow.
Because he was involved in the development of olaparib. And when he found out he was BRCA positive, he convinced his tumor board. He's a cancer researcher, so he's a scientist. He's not a medical doctor. He convinced his board to allow him to take olaparib, which he did, and he got over 2 years out of the olaparib. And then it stopped and started working, and he's just finished another trial. He didn't respond too well to it with what's called an ATM inhibitor. And essentially it's a drug that kind of turbo boosts the olaparib. Now you have other drugs like Rubraca, which is the drug that the Triton trial drug, rucaparib. The drug is rucaparib, and its commercial name is Rubraca. It's made by Clovis. And that is a more powerful version of olaparib just on its own. And then there's another drug that just got approved for breast cancer that's made by Pfizer, talazoparib. I forget what the commercial name is. I just saw it this week. And again, that's an even more powerful drug. The issue is we don't know if you even have to have the BRCA mutation for these drugs to be effective. There is a school of thought that they could be effective for anyone, but we don't know that yet. And when Soraya says to you, well, you need to be castrate resistant, that's largely because the men who have been trying it have been castrate resistant. That isn't because it wouldn't work if you were castrate resistant. And this is why I feel, if it were me, I'd be wanting to talk to some of the oncologists who are working at the BRCA Center who might have different views on how early you ought to start a PARP inhibitor.
Okay.
And that's a question that you could put to Professor Bill. He may have an opinion on that.
Great.
I mean, again, it's not going to be medical advice. He's not going to give you medical advice, but from a scientific point of view, he's going to have a perspective. And I'll tell you something. When he was going through this ATM inhibitor trial, it was AZD 6738. He was a celebrity. They were coming in, the doctors were coming in to talk to him because he was the guy that discovered the pathway to make this work back in 2004. So they wanted to come in and ask him what he knew. And Bill's really good. I mean, he can dumb it down for you and for me to explain it. He's a wonderful guy. I love him dearly. There's a lot of good news and bad news. I'm sorry I'm talking so much, but I got a lot to tell you about BRCA. And I think that if I were metastatic and I found I was BRCA positive, I would feel good about that because we know that there are drugs, precision medicine drugs that are likely to help you. I mean, the response rate amongst men that were BRCA positive was over 50%. I'll send you, Carl, I'll send you the article, and I'll also send you the link to the poster.
Great.
Because I just got it this morning. So let me open this up again to anybody that wants to talk about BRCA and Carl's news.
Yeah. This is David. So I have the ATM gene. Just wanted to pipe up about how hard it can be on kids, because I had to tell my kids about that. And it's the same kind of issue as BRCA, except not quite as severe in terms of lifetime risk for breast cancer and whatnot. But one positive is that my kids are thinking if they decide to have more children, if they're going to get tested for the color, with the color testing and see if they have or are carriers or not, that they would consider like in vitro freezing of eggs, because apparently you can separate out that genetic profile from oocytes and avail your children to not having that issue. So that's a positive, I guess, out of all the crap that is considered a negative for having to dive into this with your family and relatives and whatnot. So that's something to think about. And then the other thing with regard to the ATM gene or the BRCA gene is that the science seems to suggest that in general, these prostate cells tend to be more genetically unstable, creating more mutations in a wider population of variant cells that are all cancer. So that presents more antigens usually to your white cells. So there's opportunities for not only PARP inhibitors, but also checkpoint products that basically now have a hotter tumor as opposed to a colder tumor to work against. So that's just something else to think about for, stuff to discuss with your BRCA center down in USFC, I think you said.
UCSF, but also at Penn. There are two centers, one on either side of the country. I just posted for you I put the poster in there. I don't know, maybe you and David's on the phone. But Carl, you can click on that, and that's the poster from the Triton study. So if you click on that, it's very dense, so you won't be able to absorb it right now. And I'll send you a couple of articles about it. There was an article that it was reported by Mike Scott, but I don't think Mike Scott is accurate in his reporting. It was also reported on Euro Today, and I'll send you that link. One of the things that came out of this, which would interest David, is that it appeared that men with the ATM mutation alone did not respond to Rubraca. And it's not definitive. I mean, well, I read it a lot more definitive than Mike Scott read it. Mike Scott said it's unclear. I think the poster is very clear that men who had the ATM mutation did not respond to BRCA. So
yeah, I saw that.
Did you see that?
I did, yeah.
Yeah. And do you have the poster, David, or not?
Do I have a what?
Do you have the poster?
I'm not sure. When you say a poster, do you mean I'm on the phone? I can't see whatever.
Right. What I'm asking is if you don't have the link to the poster, I will send it to you. Posters.
Oh.
So let me explain what posters are. When you go to these medical meetings, there are usually any number of researchers there presenting their research. And the way they present them are on these large poster boards. And some of them will have actual sessions and they'll talk about them, and others will just be standing next to the poster, and you go look at the poster and you go up and you talk to them. So these when I say the poster, this is the research presented not as an article, but in kind of visual form that Clovis Oncology put together for ESMO. And I will send it to you, David. It will be of interest to you.
Rick, I saw it briefly pop up on my screen, but then it disappeared. So I don't see how do I pick that back up, the link?
If it popped up on your screen, it's probably opened a window. If you look at your windows, one of those windows will be the poster. If not, just copy the link which I gave you in the chat window, and just open a new window and put it in there.
Ah, there it is. Okay, the chat window. Yes.
Okay.
Carl, yeah, Rick, if you wouldn't mind sending that, I would appreciate it.
Yeah, I'll send it to you, David.
Okay, thank you.
Carl, I also submitted the sputum test to the color, for the color thing. How long did it take you to get the results?
It took probably about 10 days. I'm also waiting because Foundation Medicine, I had that test, which is somewhat different and more comprehensive than the color test and a lot more expensive. But it really needs the sample from my biopsy. They had an initial slide, which they said it wasn't sufficient for them to perform a test. I asked Dr. Soraya to follow up. They sent another slide, and apparently that's sufficient. And I'm waiting any day now. They also said that takes typically up to 10 days. So the color test, I understand, will test for 30 genes. The Foundation Medicine test actually is over 300, but it's different. The color test, right, is a saliva test. Foundation medicine test is a test of actually your biopsy of the tumor.
Right.
They also do a what they call a liquid biopsy of blood, which tests for about 60 or so if you don't have a good sample from your biopsy. That concerns me because I it's been about 2 weeks since I submitted my result, my test tube. So I'm wondering how long I should wait till I try to contact them and ask them about it.
Yeah, well, sometimes what happens too is that it goes first to the doctor that ordered it, and until the doctor releases it, they don't communicate with you. So I happened to be on the phone with Dr. Mark Stein, who was the person who ordered it, and he said, "I just got your results." He actually called me, and he said, "I will release them so that Color will send you an email." So
okay. Well, you're also a paying customer. I did it as part of a test.
Okay, but two things, Jay. One is two points here. One is that you can go to Color yourself. You don't have to go through a doctor. So in Carl's case, it did go through a doctor, but if you go yourself, they're going to send them directly to you. In your case, they may have been released to the lady in Washington, the University of Washington, because you're doing it through the Gentleman study, right?
Correct, yes.
So what you might want to do is look at the Gentleman study, go back there and check and see how you get your results. You may have to they may be sending them to her. I don't know. I'm just thinking about that.
Yeah, that's a good point. Good thought.
So,
yeah.
I would check first of all with the trial coordinator on the Gentleman study, and then if they can't help you, call Color. But you may find that all the test results are being sent there first.
Okay. Thank
you.
Yep.
But anyway, I mean, this is do you have siblings, Carl?
I had one. My sister, I had an older sister who passed away. Yeah.
Okay, but so you don't have any siblings that are alive?
No.
Okay. I think that you're also with your genetic history, you'd be very interesting to the center in Pennsylvania, the BRCA Center in Pennsylvania, and certainly to the BRCA Center in UCSF. I'm more than happy to connect you to the BRCA Center at UCSF as well.
Sure.
And the one thing I like with the BRCA Center at UCSF is that there's a very strong genitourinary medical oncology department at UCSF. So, so there's good crossover there. And I think, the way to do that might even be through Jim McCoy, because he's already got the in. Jim had some, was willing to consider funding some small studies there. And so he's met with Alan and he's met with Pam Munster and he's talking to them. So let me think about that. I'll send you the details I'll send you the links for both of the centers. And then if you would like to pursue, I don't know that you want to be pursuing both Penn and UCSF. That's the only thing. So I'll let you think about that and decide where you want to go. But I would strongly encourage you to get involved because it opens up a lot of doors.
Right. And it's interesting, the Clovis study, there's a clinical trial that the genetic counselor from Color mentioned to me. And I asked her, well, I'm already in a clinical trial. And she said, oh, well, typically you can't be in more than one clinical trial at a time. So she said it could be down the road.
Yeah, I don't think you have to be BRCA. I don't think I bookmarked that. I bookmarked that trial, or I thought I bookmarked the trial. I can't. I'm not going to look for it now. But I didn't think you had to be castrate resistant to be in that trial, but maybe you do. I know the Clovis people pretty well too. One of the senior science research, the senior scientist there is on our advisory board. So we know those guys as well. We have our fingers everywhere.
That's great.
All right. Well, is there anything else that you wanted to raise, or should we move along?
Well, you've spent a lot. I greatly appreciate you spent a lot of time with me. There's other things, but I will defer. There were one or two other gentlemen who wanted to talk as well during the time, so I'll defer to them.
Okay, well, hang on and let's go through. And Len, who else did we have that wanted some time?
Peter did, but I believe he dropped off.
Yes, he did.
Jake, he dropped off, right, Jake?
Yeah.
Yeah. All right, I'll call and apologize to him afterwards.
I think Joel had something he wanted to say, I believe.
Yeah, I came in the call late, so about 10 minutes late, so I missed the roll call. But I live in Reston, Virginia, and Reston Hospital started testing recently for or offering the fluciclovine PET scan. And I was wondering if any of you guys had ever taken that scan and how good it was, and how far down a PSA will it go? I think it goes down to a 0.5, but I may be wrong about that.
Is this the Axumin study that you're talking about? Is this?
Yeah, that's the same thing, right?
Mm-hmm.
Okay.
Yeah, fluciclovine is Axumin, Rick.
Okay, go ahead, Len.
Well, when you say it's good down to 0.5, it's a statistical game. You know, the higher your PSA, the greater the probability that fluciclovine, Axumin, will pick up lesions. It works best between 1 and 2. The further down you go below PSA of 1, the smaller becomes the probability that they're going to pick up the lesions.
Right. Okay. Got that. Yeah, I agree with you on that. That makes sense.
Yeah, there are definitely more sensitive scans. However, I believe that fluciclovine is probably the best that is FDA approved already. If you want access to the gallium-68 PSMA scans, they are more sensitive, but they are, as far as I know, they're only available in clinical trials. If you can get into the clinical trial, that's good, but you may not. And if you don't, you'll have to pay for that particular scan.
Right. Right. Yeah. Yes, I agree. There's a lot of clinical trials doing the PSMA right now, all over the country, actually, and actually all around the world. But and they'll take people down to 0.2, I think, 0.2. But I'm at 0.3, so I'm in between those two things. But I think the fluciclovine, based on what I know, is more sensitive than the choline PET or the acetate PET, and not as sensitive as a PSMA can be.
That's also my understanding. At 0.3, I'd say the probability of fluciclovine picking up lesions for you would be fairly low.
Right. Right. I'm 7 years out from surgery, and I didn't want to go the radiation route or the ADT route if I didn't have to because of its complications. So I'm waiting to find out where my cancer is so I can go directly to the spot and treat it.
Right.
All right. Well, thank you. That explains your thoughts on that are about the same as mine. Thank you very much. Appreciate it.
And did anybody else want to say anything on the Axumin scan? Is there anybody on the call who's had an Axumin scan?
It's too bad Peter dropped off. He seems to be the expert on all these different scans.
Yeah.
And he keeps on top of all of them.
Yeah. Okay. Well, it is a little bit of a crapshoot, as Len said, at those lower levels, and probably better to wait. I don't know. What's your thinking, Joel?
Well, I seem to have abided on this course of action where I am waiting for the past 7 years. So I figured I might wait a little longer to see if my PSA goes up some more, or if some better scan comes along. I just read today that the PSMA treatment arm, the treatment side of the PSMA scan, is now introducing a molecule with chemotherapy in it to kill the cancer when PSMA gets expressed by the cancer cell. So I'd never heard of that before, but there's some clinical study someplace that looked at.
Yeah, I saw that last week somewhere. I don't know much about it, but I did see it. But there are. I mean, the PSMA scan is more refined, and then the one that's being tested at the NIH, National Cancer Institute, is even more refined. The 18F pyridium, is it, Len? Is it pyridium?
I don't know it by a name. I only know it by letters, and I know the last 3 letters were PYL.
PYL. Yeah. Okay. Yeah. So there are a couple of other that you could check out, but as Len said, you're right at the margin anyway for all of them.
Joe, what's the history of your PSA progression?
Prostate taken out 7 years ago in August, and PSA came back 6 months later at 0.02. It's gone slightly up, slightly down, up until it reached 0.2 for a 4 3-month period in a row last year. And from 4 readings of 0.2, it's now jumped up to 0.3 as of August of this year.
So what period of time between 0.2 and 0.3?
6.5 years.
Oh, I think you're sitting pretty good. That's an extremely long doubling time. You probably don't need to do anything, and that's my opinion, not advice. But I don't. If it were me, I wouldn't worry about it at all. I wouldn't worry about scanning.
So can I just pipe in here? One thought too is that if you had a radical prostatectomy and they left just a little tiniest bit of healthy prostate tissue behind, that it could just be humming along, popping out a small amount of PSA, right?
Right.
Yeah. Well, yes and no. I mean, the thing is that if it could be, but then it would just always be the same. So you wouldn't ever see an increase from it.
Well, the surgeon who took my prostate out 7 years ago, the last time I saw him was in January of this year, and he declared me cured of prostate cancer based on my PSA readings. And that waved about 12 red flags in my face, and I don't believe him. But if he's right, that's great, but I don't think he's right, because my PSA since then has jumped up to 0.3. And I don't know what the behavior is of prostate cancer cells left behind. Do they fluctuate with a PSA? Does a PSA fluctuate as a result, or can it climb? I don't have any history. I haven't read anything about that yet.
Well, my understanding is that if it's there, and it produces the PSA, and it's, generally a consistent amount. It expresses its prostate-specific antigen, and it can be the cause of having a residual PSA, but I don't think it jumps around.
Yeah. So yeah, well, that's logical to me too, because it probably doesn't grow. So until they come up with a test that tells me which is which, for sure.
You're right.
Then I'm going to be continuing to study this and try to do what's best.
So I have a note that your PSA was 0.3 back in June of 18. Have you been tested since?
No, that was actually I don't know why your note says that, but it was August of 18.
It was August. Okay.
Yeah. And before that, I had four 3-month PSAs at 0.2, 4 in a row.
Yeah, I have that down. So so when are you due to test again?
November 8th to be exact.
Okay. Well, let's see what that says. That might, be helpful.
Yeah. If it should jump up to 0.4 at that point, then that might be very serious. Or if it should be at 0.3 again or 0.31, then it may not be so serious.
Right. Are you doing an ultra-sensitive test?
No, I'm doing the in-between one. I think no, it's not ultra-sensitive, no.
So is it only to 1 decimal point, or is it to 2 decimal points or more?
It's to 2. It's my first reading was 0.01.
Okay. All right. As long as it's at least to 2. I just want, as long as it's at least to 2 decimal points, I think that's good enough.
Right.
Okay, well, the worst thing you can do is get over anxious. I mean, I know I always say that. I know it's easy to say, but it is the worst thing you can do. So hang in with it and talk to us, and we'll come back to you.
Do you have anybody else ever had on a call where they've claimed their doctor has told them that they had residual prostate cells left behind?
Oh, yeah.
Okay.
Yeah, no, I mean, I wouldn't say it happens that often, but it certainly can happen.
Okay.
So, yeah.
I can, Joe, I can tell you my own experience. My PSA has been at 0.5 for the past 11 months, unchanged. It was steadily going up to 0.5 post-radiation, but once it hit 0.5, it stayed there. My oncologist said, you're entitled to have some PSA, whatever that means. But in any case, he wasn't too concerned about rushing me in for imaging.
Right. Yeah, that makes sense. Did you have surgery and radiation, or just radiation?
Just radiation.
Okay.
And ADT.
And ADT.
Although I haven't been on ADT for the period that I just described, where the PSA has been stable.
I see. But you've never been down to 0.01, right? Because of radiation. Never. So you're expected to have a little higher PSA because of the radiation treatment.
I suspect so.
Yeah. Okay.
So I just got a text from Peter that he had some new information and he wanted to discuss the results with us, but he had a cardiologist appointment. I guess, did he say that he had to leave after an hour? I can't remember. 2 people did. John Appler did.
Yeah, John Appler did, but not Peter. He didn't tell us.
Yeah, I didn't think he did. Anyway, it is what it is. I'll call him later. Or maybe Len, maybe you and I can call him later together. We'll
Sure.
figure it out. Yeah. So is there anyone else on the call that would like to say something? Shref, what about you? Shref?
I think we lost him, Rick.
I'd like to pipe in.
Yeah, go ahead, David.
I was wondering if anybody has done any work with, speaking of testing and diagnostic testing and such, with the circulating tumor cell assay as a part of their therapy prognostication process.
In what specific context?
Well, there's a lot of talk about doing imaging to try and locate stuff and things of that nature. But if you're high risk, it's possible that you have mets floating around, these circulating tumor cells.
Right.
And I'm guessing that there's probably certain therapies that might knock those down and others that might not. And I'm just curious if anybody's working with an oncologist or, and has had any experience with, tackling that as something that might be relevant to their long-term health care.
Len, do you want to talk about liquid biopsies first, or do you?
Well, I really can't speak from personal experience. I had one CTC test performed when I was newly diagnosed with a Gleason 9 and had spread beyond the capsule. Fortunately for me, that was non-detectable, but I haven't had any since. They've never ordered it. I suspect they only order it when you have metastases and they want to monitor how well the treatment, how well you're responding to treatment. That's all that I would say.
So I would add a couple of things, David. I mean, first of all, the CTCs are the underlying science behind the liquid biopsy. And there's a very good animation, I think it's linked on our website, that explains how, and it's short, and it's simplistic, but it basically shows how they can capture the tumor cells from the bloodstream and then analyze them. It's a Foundation Medicine animation. Now, there needs to be a minimal level of CTCs in order for the tests to be effective. And we've had guys that have gone through CTC testing for liquid biopsies, and they're not shedding enough tumor cells into their bloodstream. I'm sure I don't know that others will, that the science of the CTCs is based on the fact that the tumor sheds part of its cells consistently, and those go into the blood, and so they take blood and they try and capture, and there needs to be at least, I don't know what the units are, but there need to be at least 4 of these tumor cells in whatever the volume capacity is, 4 per, I don't know the volume capacity, somebody else may on this call. But you need a higher really than 4, and usually you don't see that until you have a certain burden of metastasis. So if you are castrate resistant, for example, but you don't show metastasis, then the liquid biopsy is probably not going to work for you. So the two uses that I'm aware of for CTCs is, one, for the purpose of doing a liquid biopsy. And the other is just to measure the effectiveness of treatment, which I've only ever used in clinical trials.
Yeah, I was just kind of thinking, if you have those buggers floating around in your body, it might motivate someone to take a more aggressive stance in terms of what they want to do up front. There's a whole school of thought that aggressive prostate cancer should be treated aggressively rather than sequentially. I don't know, that's just one school of thought. But for instance, for me, I'm very uninclined to do chemotherapy and radiation based on my gene defects, but I might be cajoled into doing that if a bunch of these buggers were floating around, or at least, something more than what I'm doing right now.
Well, I don't know. I need to pull up. Right now, you just know that your PSA is back, but you don't have indication. You don't have any indication. Isn't that right?
Yeah, I just had the surgery, 3 months ago, so I'm non-detect for PSA presently, but I have no illusions that that's a done deal, because they took out lymph nodes that had it in them, so I'm pretty sure it's somewhere else in the system at a time. I'm just trying to get my arms around it.
Right. And you're ATM positive, correct?
Yep.
So, again, it might be, and I know you're working with Heather Chang, but it might be an idea to reach out to the BRCA clinic and see what ideas they have, the UCSF BRCA clinic. She probably knows Pamela Munster. And the reason I say that is only because, well, first of all, ATM is in the pathway, in the BRCA pathway, but it doesn't necessarily respond, as we know from this Triton trial. But it is in the BRCA pathway. So, it might be, and it might be interesting. It might also be interesting to see if there are any appropriate trials, because as part of those trials, they may be doing regular CTC checks.
Right. What's the gal's name there again?
What's the woman's name where? At UCSF? Yeah. Pamela Munster. Munster. She's pretty phenomenal. Okay. She's a med-onc. She's BRCA positive. She has breast cancer. She has kids. She's really quite special. I've heard her. I've met her one time, and I've heard her talk. And you can find when I send you the poster, I'll put some information on the BRCA Center, the UCSF BRCA Center there. And I think if you reach out through Heather Chang, you will probably be the way to go.
Yeah.
Okay.
Sounds good. Thank you, Rick.
All right. It's past the witching hour. Talking about past the witching hour, was anybody fortunate enough to see Jake Hannum's impersonation of Dracula? No?
Not I.
Well, why would they want to see this again? They've already sat through 2 hours. They're not going to go and listen to the recording.
Well, for those of you, Jake, would you like to explain what the relevance of that comment was?
Right. As you know, we always record these sessions on the high risk call, and they also have when we record it to the GoToMeeting server, we also get a semblance of a translation, which is a transcription of the voice, which is nice. It's not real accurate, but it's somewhat accurate. But you can't upload that to YouTube. So what we've been doing is making a little video on YouTube, because that's where we have our main host. And I make a little video, or Len made one a couple of weeks ago, saying, "Hi, this is Jake, blah, blah, blah. Click here to go see the video." And then the link takes you then to the link on GoToMeeting, where you can actually see the transcription and the full video. So anyway, Len got a little bit creative 2 weeks ago. He did Alistair McLean.
No.
Even though he didn't pronounce
Alistair Cook
properly.
Alistair Cook.
Alistair Cook. But he mispronounced Tuesday, apparently, according to Rick. And then, in the spirit of Halloween, last week I did I lip synced to one of my favorite movies, Dracula, Bela Lugosi. So that's the reference.
Well, we don't think it was a lip sync. We think it was actually Jake, and Jake says it was a lip sync, but we're not certain about that. So if you want to see Jake, go to our YouTube and switch on and turn on last week, and you'll see Jake doing his Dracula imitation.
Right. It's only 45 seconds. It's not long. It won't keep you very long at all.
Okay. All right, guys. Next Monday, we'll see you. See
all
you
right.
all then.
All right.
Okay.
Thank you.
everybody.
Good night.
Good night.
Have a good
Bye.
night, everybody. I guess I'm in charge of unplugging us here, aren't I?
Yeah, I'll let you unplug.
And meeting for all. See you, Rick.
Bye.